Hi, everyone. I'm Marisa Ciarlitto, and I'm excited to be here with Dr. Jennifer Zelovitzky, the Clinical Director for the Women's Health and Vitality Program here at Medcan. Hi, Dr. Zelovitzky. How are you?
Well, Marissa, thank you. How are you?
I'm great, thank you. I'm so excited about today's Eat, Move, and Think podcast, as we're going to be talking about the new perimenopause and menopause program that we recently launched. How does it feel after all the hard work that took place to now see this program start to help so many women?
Oh, I can't tell you how gratifying it is. It's been gradually picking up steam, and I think it's going to continue to do so into the future.
100%. Is it what you expected?
I have to say, in some ways, yes, because I certainly knew going into this area of care and having worked in this area of care for 2.5 years that there is just a vast need for this type of service. It's not available to a great extent in the community. And where it is available, the wait lists are increasing and they've ballooned to anywhere from 1 to 2 years. That's simply too long to wait to start to attack some of these symptoms that are truly debilitating.
2 years to wait to see a physician.
In some cases, yes.
Wow. What are some of the surprises that you've learned with the launch of this program?
Interestingly, I've been somewhat surprised by how similar the stories are. Women will tell me the same story about their day-to-day life or their work experience almost verbatim. There are a lot of women out there who are having to start writing everything down on notes all day long, whereas they used to feel very, very sharp and have a very strong ability to remember what they had to do in a given day.
Yeah.
There are the classic symptoms like the hot flashes, the vaginal dryness, the low libido. But I'm realizing more and more that the vaguer symptoms like fatigue,
Yes.
joint pain,
Yeah.
brain fog,
It's a lot of symptoms.
these are things that are far more common than I think we classically come to think of menopause as being associated with.
Yes,
That's been quite surprising to
that
me.
is. And that is a long list.
Oh, yes. The list is vast.
Wow.
Yes.
So I know you had a great chat with Allison Hazel not too long ago on the Eat, Move, Think podcast, which was episode 176. And that conversation covered a lot of ground on perimenopause and menopause and all of the symptoms and challenges that come with it. I know if any of our listeners missed that episode, I would recommend listening to it because it provides the full details on the myths, the misconceptions. Why don't we do a little bit of a quick recap on some of those highlights? What is the difference between perimenopause and menopause?
Okay, that's a great question. Menopause is a point in time. It's the point at which a woman has gone 12 full months without a menstrual period.
Okay.
At that point, we call it menopause.
Okay.
You can only really know what your menopause was looking back on it retrospectively. Perimenopause is the period of time leading up to and following that final menstrual period. And it's really the perimenopause that produces all of the symptoms that we think about: the night sweats, the hot flashes, the brain fog, the irritability, those types of things.
Is there a certain time frame when that occurs, the perimenopause?
It can be highly variable. Typically, it can be anywhere from 1 to 4 years before the final menstrual period and can last anywhere up to, 4, 5, even 10 years after the final period.
Should a woman be concerned if her monthly menstrual cycle has changed during this time period?
In some cases, she could be concerned. It's difficult to know because it can be quite normal or common for the menstrual periods to change. That is, in fact, one of the hallmarks of the perimenopause, is that the periods can become closer together or very irregular.
Okay.
And then as you get closer to the final menstrual period, you'll start actually skipping a period, and you can go 60 or longer days, 60 or more days without a menstrual period.
Okay. Wow. What are some of the symptoms you commonly see in your clients at Medcan?
So there's the big ones that people think
Yes.
about. There's the hot flashes, the night sweats. You can get heavier or sometimes lighter
Mhm.
periods. So the
Mhm.
changes in the menstrual cycles. You can get skin changes. So dry skin, burning skin, a sense of something maybe crawling in your skin.
That's all part of
This can be
Okay.
some of the symptoms of menopause. You can experience weight gain, particularly developing more fat around your midsection,
Okay.
the redistribution of your fat. You can get brain fog, you get mood changes, especially irritability
Mhm.
or a sense of anxiety. You're lying in bed at night and your heart's racing and you're feeling anxious, and that's out of character for you,
Mhm.
or you can't put your finger on why. Sleep disruption. Even if the quantity of sleep stays the same, the quality of sleep
Mm.
can decline at perimenopause and menopause. So you wake up feeling that you slept, but you're not refreshed.
Yes.
Then there are the vaginal symptoms, vaginal dryness, frequent urinary tract infections, or just a feeling that you have to avoid your bladder all the time, low libido, pain with intercourse, lack of sensation, and difficulties achieving orgasm. These are some of the common symptoms that can occur with perimenopause.
Do women get just one symptom? Do they get 2 symptoms? Like, how many symptoms?
That can vary. I have met many women who will have 1 or 2 very specific symptoms.
Okay.
There are women who have no symptoms. Really, there are women who don't experience symptoms, but that's rare. And then there are women who seem to have all of the symptoms.
Yes.
So it can be highly variable.
How can a woman, navigate menopause gracefully? What advice would you give as they're going through all of these different challenges and these different symptoms?
The number one thing is to start by giving yourself some grace.
Mm.
Menopause in and of itself is extremely challenging and scary because we
Yes.
just don't talk about it as a society. We don't have a sex education class like we do in the 8th grade. No one sits us down at 40 and says, this is what you have to expect in the next 10 years. So we have no idea what to expect, and we don't know how our individual body will respond to the perimenopause. So we start by giving ourselves grace. This is a time in our lives when we're often balancing a family, a
Mhm.
career, caring for elderly parents. We're trying to make sense of all of that on top of these new scary and debilitating symptoms. And so to get further into what do we do about that? The first thing is to maintain a very healthy lifestyle. And to be more specific about that, it's about what you eat,
Mhm.
what you do in terms of substances, and how often you exercise. So you
Mm.
don't want to be a smoker. You want to minimize your alcohol intake. You want to get that 150 minutes of vigorous exercise every week. And then you want to advocate for yourself. Don't take these symptoms lying down. There is help out there. You may have to ask a few different doctors. You may have to ask your doctor for a referral to see a certified menopause practitioner. But help is out there. Advocate for yourself. You don't have to suffer in silence.
And we don't want anybody to suffer in silence. And we are
No.
so grateful that we have you leading the program. And you are NAM certified. It's incredible. So you're
Thank
going to be
you.
able to help so many women. So thank you for that.
Thank you. It is truly a privilege because there aren't enough of us out there.
No, there's not. Especially as you said, a 2-year wait list. That's a long time.
Absolutely.
I wanted to get you to maybe just to share with everybody what it means to be a NAMS physician.
Yes, sure. I want to put in a little caveat there because the North American Menopause Society, which is what NAMS stands for, has recently changed their name to the Menopause Society.
Okay.
So that might create some confusion out there, but going forward, they will be known as the Menopause Society.
Okay.
However, if you search online under the North American Menopause Society, it will link you to the website regardless. So this is a program by which you can do additional training as a menopause certified practitioner, which I have become now. And so therefore, I'm well versed in not only the symptoms and the health issues that arise as a result of perimenopause and menopause, but also the various treatments, hormonal and non-hormonal, that are available for women who are struggling at this time of their lives.
This is incredible because for women to be able to go and see you as a NAMS certified physician is going to be such a key asset for them.
Yes, because unfortunately, I think we're too few and far between at this point in time. I hope in the future that more people will engage in this training, particularly family doctors, because I think it's important that they have this skill set. This represents a huge proportion of their patient population. And looking back now on my career as a family physician, I think back on some of the patients I saw that were really struggling with their health. And now I see so clearly that many of their symptoms were likely due to the menopause transition. At the time, I simply didn't have the skill set to recognize or to manage it for them.
I know it's scary for women when they start seeing changes to their body. So you've just identified a lot of these symptoms. So how can a doctor help you learn whether the changes in the body, they're caused by menopause or it's caused by something else?
That's a great question. Often we sort of go to the doctor now in this day and age with all of the internet availability of information or from speaking with other people. We go to our doctor and we want to diagnose ourselves. We all do it. It's human nature. We do know our bodies better than anybody else. And you may very well be correct. However, there are other processes, disease processes, or common illnesses that can mimic the symptoms of menopause. For example, anxiety can be a true mental health disorder, and we want to tease out whether it is truly because of the fluctuations in the menstrual periods or the change that accompanies that in our hormone levels, or is it truly anxiety for another reason that should be treated differently? We could be gaining weight or feeling tired as a result of a thyroid disorder. So we want to rule that out first. In some ways, menopause is almost a diagnosis of exclusion. You want to make sure that there's no other concerning cause for your hot flashes, your night sweats, your mood changes, your cognitive decline. Once those have been ruled out, we can then start to approach it as a potential perimenopause or menopause.
So it's a step-by-step process, which becomes critical in working with your physician.
It is. It's important to tell your doctor what you're experiencing, but allow them to keep their differential broad at the beginning, because you don't want to miss something, such as, for example, a thyroid disorder that could be treated with a thyroid replacement.
Amazing. We've had so many questions to choose from this episode.
I know. It was overwhelming.
There was a lot. I want to ask you, how many questions do you get on a regular basis from your patients?
I get tons of questions. I think there are a lot of misconceptions and there are a lot of mixed messages out there, especially on the internet and in society at large. We touched on the Women's Health Initiative study in our last podcast, but I heard someone say the other day that, once an alarm bell is rung, it's very difficult to unring it.
Okay.
People remember the initial message that hormone replacement can be dangerous.
Yes.
And it's going to be a long and slow process to re-educate society with respect to what we now know to be true, which is there were some flaws in that study from the perspective of the intention of the study versus how we're actually using menopause hormone therapy and who we're selecting as our patient. So I get a lot of questions around safety, particularly.
Okay. What's it like to hear the same concerns from so many women who don't have the information that they need?
I see it as a valuable opportunity to start changing the message. It's an honor that they're coming to me and they're trusting me. Often we're meeting each other for the first time and they're trusting that what I'm telling them is going to be valid and evidence-based information. It helps them to clarify some of the things they might have heard or read or understood to be true about the menopause experience or about the therapies for menopause.
Yes.
Whether it's hormonal or non-hormonal, we want to be using medications that are that are validated, that are tested, that are
Mhm.
consistent in their formulation.
Yes.
It is very important when we're talking about any medication.
Mhm.
And therefore, why would we not expect the same from our hormone replacement?
Agreed. So let's go over some of the common questions or concerns that you're
Sure.
hearing from your
That would be
clients.
great.
So we have the first one. How can I know if I'm getting enough vitamin D and enough calcium?
This is a great
Okay.
question. And this is another common concern. The recommended intake for vitamin D is about 1,000 units a day, although it can vary depending on your individual diet
Yes.
and your exposure to the sun, for example, or your vitamin D level.
Mhm.
So it is important to know what that is going in. Calcium, the recommended intake for women of menopausal age is 1,200 milligrams a day from all sources. I believe it's best to get your calcium from your diet. However, some women are lactose intolerant or prefer for other reasons not to consume calcium-enriched foods. Therefore, they could take a supplement.
Okay.
Although I always advise patients, the body cannot absorb as much calcium from a supplement. Therefore, you don't want to take more than 500 milligrams of supplemental calcium at a time.
So you can supplement that with the food and the
Yes, to make sure you're getting the right amount of calcium and vitamin D to answer your question. Osteoporosis Canada's website has a wonderful tool called the calcium calculator. This will allow you to plug in your typical intake and it will let you know whether you need to be supplementing
Okay.
with calcium.
This is going to help the bone health.
Absolutely. It's crucial for preventing osteoporosis and therefore preventing fracture, which carries a very high morbidity and mortality rate.
Another question. Are pap tests and mammograms required during menopause? So when women are going through that, do they need to do those tests?
Absolutely and emphatically yes. A pap test is crucial for detecting the early signs of cervical cancer. Women should continue to have regular pap tests, that is every 3 years, as long as they're normal, up to the age of approximately 70, whether they are in a long-term relationship or not. It's very important to catch it early because cervical cancer is a devastating disease. With respect to mammograms, it depends very much on the individual circumstances. However, mammograms typically would start between the age of 40 and 50 and continue every 1 to 2 years until approximately age 74, 75. But be guided by your doctor and make sure you stay up to date with your screening. That includes colon cancer screening, which should also start approximately age 50, although in the United States, they've recently revised that down to 45. So Canada may follow suit in the near future.
And it's about taking preventative steps in terms of the health journey.
Absolutely. It may be inconvenient or uncomfortable to go for a pap test or a mammogram. Certainly tell your healthcare provider if you find these tests uncomfortable, and they can do things to make it easier for
Okay.
you or accommodate you. But it is far more inconvenient, uncomfortable, and truly devastating to face a cancer diagnosis that could have been prevented.
Yeah. Moving on, more questions. So
Mhm.
from what I understand, a lot of common questions you hear are from hormone replacement therapy, from women even who are already going through the therapy.
Yes.
How common is hormone replacement therapy these days, and what's the importance of timing?
I would say it's becoming more common again.
Okay.
It's not quite, I don't know the numbers, but I know that after the Women's Health Initiative, it dropped to about 4% of
That's
women
low.
that were on hormone replacement therapy. Interestingly, I'll just sidetrack for a minute. They didn't really see a decline in breast cancer, cardiovascular disease, and all of the other things that they thought it was causing. They really didn't see it, but no one reported that. But regardless, so use declined dramatically.
Yes.
People were terrified. Doctors were terrified. You know, as a family physician,
Yes.
looking back, we really weren't taught about this other than to say, it's very risky. Don't do it.
And no one did it.
And no one did it. It's not their fault. They weren't educated in this area of care, so they don't touch it. what I am so happy about now is what used to be a very tough sell to convince people of the safety and efficacy of
Yes.
hormone therapy has now flipped itself on its head. I think we're being assisted by the reanalysis of the Women's Health Initiative, which is finding its way into the mainstream media. And so women are learning that there were some conceptions they had about hormone therapy that were wrong. And more often now, they are approaching me saying, this is something I've looked into and I want to do for myself.
They're being proactive and they're being
Yes.
an advocate. Just as you've highlighted, we need to take a stand and be
Absolutely.
advocating for ourselves.
Absolutely.
Amazing. What are some of the biggest concerns you hear from women on hormone replacement therapy? So some of these questions are, I started on hormone replacement therapy and initially it worked well, but it seemed to wear off. What's happening?
This is a very common question that I get. We always start with the lowest dose because every woman's estrogen receptors are highly individualized. We don't know how well she's going to absorb the estrogen as an individual, and thereby we don't know how well she's going to react to that particular dose. We certainly don't want to hit a fly with a sledgehammer, so we start low and we work our way up. So often I will get the question of, well, it's been a month. When I put the patch on, it was amazing. All of my symptoms seemed to disappear. But 2, 3, 4 weeks into it, they're starting to creep back up again.
Okay.
And they ask, does this mean I will have to keep increasing the dose? The answer is no. This very commonly happens because the body just feels this tremendous sense of relief to have some estrogen and it goes right to work. But then things start to balance out again and we find out perhaps this isn't the right dose for you. We increase the dose incrementally until we reach that optimal dose. And often a woman will stay at that dose indefinitely.
Okay. And that's why it becomes important to see your physician who understands all of this.
Yes. One of the main things about our program that is so crucial is that it is a 6-month program, and then women are encouraged to have an annual follow-up through Medcan in order to make sure that their screening stays up to date, that their dose is still appropriate for them, and that at approximately the 3 to 5 year mark, we consider whether she still needs to be on hormone replacement therapy. It is not meant to be taken indefinitely. Certainly, we know that the risks do start to increase after 5 years, and we're very mindful of that.
Yeah. And I remember having lots of conversations when we were trying to determine the length of the program. Should we do it for 3 months? And you were a big advocate because you wanted to have that checkpoint at the 3-month mark for women.
Absolutely.
And this is where then it resulted in a 6-month program. So yeah, it helps with that.
And at that point, if their family doctor is comfortable to maintain their prescriptions, that's wonderful.
Yeah.
Otherwise, they're welcome to see one of our physicians who's comfortable managing women's hormone health at Medcan for their annual follow-up.
Perfect. How can hormone replacement therapy help with weight gain? Another question.
Yes, this is an extremely common question. I wish I had the answer people wanted, but I'm very honest about this.
Okay.
Studies and my own experience have taught me that hormones will not make you lose weight, but what they will do is support your efforts to lose weight.
What does that mean?
So, with the assistance of hormone therapy where appropriate, women often find they're sleeping better. They're having more energy. They're able to exercise again because their muscles and joints aren't as sore. And so they start moving more. I encourage women to start doing resistance-based exercise. We have to start replacing and maintaining our muscle mass. These are the things that allow for weight loss to happen. So the hormones in and of themselves don't cause you to lose weight, but the advantages and the benefits of the hormone replacement therapy will give you a boost and a lift in your efforts to lose and maintain your weight.
Okay. Wow. More questions on hormone replacement therapy. Can it be combined with other daily medications?
Yes, it can.
Okay.
There are very few medications that will interact with hormone replacement. One major one that I want to touch on is thyroid replacement.
Okay.
For women who are on a thyroid replacement pill, which is extremely common,
Yes.
they can impact each other, basically, the absorption of one another. So it's important to check your thyroid levels 6 to 8 weeks after initiating hormone therapy or changing the dose of hormone therapy
Okay.
to see if you need to make an adjustment in your thyroid medication.
And then and then it'll be safe to use
Absolutely. Another big one is women who are on aromatase inhibitors, such as letrozole or anastrozole, or a medication called tamoxifen,
Okay.
which is used commonly after treatment for breast cancer to prevent a recurrence. These medications can interact, and often it's contraindicated to have hormone therapy when you're on those medications. So you want to check with your doctor, make sure they're aware of all of the other medications that you might be taking.
What are the differences between the available forms that are out there of the pill, the patch, and the gel of hormone replacement therapy?
Okay, so the pill form, we commonly think about an oral contraceptive pill. And for perimenopausal women who are still having periods, we can certainly treat many of their symptoms by using an oral contraceptive pill,
Okay.
often a low dose one. And they're very surprised to hear this. But we have to remember that in perimenopausal women, we have to worry about contraception. They can still get pregnant.
They can?
Yes. Up until about 12 months after your last period, it's still a possibility.
Wow.
So we want to think about offering hormone replacement at a level that is also providing contraception.
Yes.
So there is the commonly used oral contraceptive pill. There are oral forms of postmenopausal hormone replacement. Some combine estrogen and progesterone, and others are just an estrogen. Progestogen or progesterone is commonly given as a pill.
Okay.
So it is taken each night at bedtime. And this is because progestogens are not as well absorbed in patch or gel form as they are through a tablet. So
that's more effective.
Injection, which would not be very convenient or desired by many women.
Yes.
Or a pill. Okay, so that is one that is commonly given orally. One important thing for women to understand and to know is that if you have side effects from the progestogen tablet that are undesirable, such as ongoing breast tenderness, mood changes, or headaches, you can use the tablet vaginally. As long as you insert it each night, it can be just as effective.
And it'll avoid some of those other symptoms.
Absolutely.
Wow.
I really want to also say that often women don't understand why they're taking the progestogen because the estrogen does the heavy lifting with respect to the symptoms rather of menopause. What is crucial to understand is that if you have a uterus, you must take a progestogen. Otherwise, the lining of your uterus can become thickened and develop a cancer. We do not want this. So I'm very explicit with my patients when I explain to them why they need to take their progestogen along with their estrogen.
Okay. Wow.
So the patch, to move on, is there is a combination estrogen progestogen patch, and this is a special formulation of progestogen that will absorb well through the skin. And so they can be given together.
Okay.
Or more commonly, estrogen alone can be given in a patch form.
And does this patch cause irritation?
In some cases, it can cause irritation. One way to avoid that is to make sure you rotate the site. So the patch can be put anywhere between the waist and the mid-thigh, but it's important not to use the same location more than once in a row. You want to keep moving the location so that you don't cause not only irritation of the skin, but it can start to affect the absorption. You can oversaturate one part of the skin, and you want to avoid that. The patch would be changed twice a week, so it's very convenient. It's typically changed, I will say, on a Wednesday and Sunday, for example, and then you sort of set it and forget it. You can go about your life. The other beauty about the patch is it can be cut. So sometimes we can modify the dose simply by using half a patch or 1.5 patches. They're designed to be cut and they still provide even absorption.
And you're providing the guidance to the women, the patients, as to what they should trial, what they should do in terms of that.
Absolutely. Just bear in mind that the level and dose of the progestogen might have to be changed based on the estrogen level. And so you want to do that under the supervision of your provider and not just play around with it yourself.
Yeah.
The gel is an estradiol gel, so an estrogen gel. It has to be applied every day. And so for many women, there's a convenience factor there. Oftentimes they'll opt for the patch because they don't want to have to do anything every day.
Mm-hmm.
They're busy enough. However, I have had some cases where, for example, a patient was a very avid runner and would get drenched in sweat with her workouts. And she found the patch would slip off. It's pretty durable.
Yes.
It stays on for showers. It stays on for workouts. But in her case, she was sweating so excessively that she needed to switch to the gel.
But that's good that there's different options that are available.
We are so lucky right now. Not only do we have different options in terms of how we deliver the hormone, but many of the hormones that are prescribed are body identical. These are structurally and functionally identical to the hormones that are produced by our own bodies. Therefore, side effects can be minimized.
Amazing.
And that a lot of women, they really want to know that what they're taking is natural and in line with what their normal bodily functions are.
And I think there were a lot of misconceptions before with this hormone replacement therapy because of that.
Absolutely. The term bioidentical just took off. And in part, there were no other options for women. They had to seek out alternative methods and providers to treat their menopause symptoms because they just weren't getting anywhere with the traditional medical system.
Yes.
But again, I always come back to the fact that whatever product you use, it should come with an insert in the package advising you of the exact formulation that you're getting, how it was tested, where it was manufactured, and it should have an outline of the risks and benefits of that medication. Otherwise, you simply don't know what you're getting.
Let's jump to lifestyle changes and in terms of how can that help to manage the different symptoms that you've been talking about for perimenopause and menopause. You touched on it a little bit.
I did. I held back a little because I sensed more questions might come up in this area. But as I mentioned, lifestyle is such a crucial part of this. Unfortunately, studies haven't really supported the fact that lifestyle alone will treat debilitating menopause symptoms, but it will certainly help to reduce them somewhat. And it will help you to manage yourself to make sure you're getting a good night of sleep and that you're stabilizing your mental health as much as you possibly can during this transitional time. So let's start with sleep. 7 to 8 hours a night is optimal for women at midlife. There are studies that show that getting less than 7 hours per night will lead to excess weight gain. And this is often something that piques people's interest because they certainly want to minimize the weight gain that accompanies the menopause transition. So aim for that 7 to 8 hours a night of good restful sleep. This can mean incorporating better sleep hygiene, whatever that means to you, avoiding exercise for 2 hours before bed, avoiding excess caffeine particularly in the afternoon and evening, avoiding too much fluid after 7 or 8 p.m.
Why is that?
Because you'll be up peeing a lot overnight. And this is very disruptive. And then you get back into bed and you just can't fall back asleep because your mind starts focusing on the next day. Exercise. Exercise is very important, but often we have to change the way we exercise.
How's that?
Well, as women, we often exercise to get smaller. I want women to exercise to get stronger. Cardiovascular exercise is very important for your heart and for your brain. So certainly we need cardiovascular exercise.
Yes.
But we need to start doing some resistance training and incorporating that into our daily lives. It doesn't have to be more than 3 times a week. But you have to think about the fact that we start to lose muscle mass at midlife. And it's very important to maintain it as best you can. Muscle will burn fat and will increase your metabolic rate. And this is very important heading into midlife. Sometimes I'll tell women if they have teenage sons, I'll say, do you notice when your son goes to the gym, he's not trying to fit into his smaller pair of pants. He's trying to get muscle.
Yeah.
We have to think that way too.
Okay. We have to change our minds.
We have to change our mindset. Of course, we want to avoid harmful behaviors like smoking.
Yes.
We want to minimize our alcohol intake.
How much should we minimize it?
Well, the new Canadian guidelines are pretty strict.
Yes.
So they put alcohol intake on a spectrum of risk. So 0 to 2 alcoholic beverages a week
Okay.
is low risk behavior
Okay.
in terms of cardiovascular disease and cancer.
Okay.
3 to 6 drinks a week is moderate risk. And 7 or more drinks a week is high risk. So if we're looking to minimize our risk, you have to sort of look at where you want to be sitting on that spectrum.
Yeah.
So I will often tell people, focus on reducing the quantity of, for example, wine that you pour into your glass. Many people enjoy the ritual of having a glass of wine with dinner, but maybe reduce the quantity.
That's a good point.
I've heard people coming up with ideas. They share a beer with their friend when they're sitting on the porch or at the ball game. And so these are things that people can do to reduce their intake gradually and in a way that won't feel so severe and dramatic to them.
And it'll help with all of the symptoms and the lifestyle changes.
It really will. And also we can't forget that at midlife, the risk of heart disease, of stroke, of cancer, that all creeps up, whether we're on hormone therapy or not.
Yeah.
That is a risk that we're accepting as we get older. So why not do everything you can to minimize it? With respect to diet, you want to avoid processed foods and refined sugars. You want to start eating a whole foods diet. You want to recognize that we often don't need the same caloric intake at 50 or 60 that we needed at 20 or 30. So it can be listening to your body, recognizing when you're full, using distraction techniques when you feel like snacking or you feel anxious, or maybe reach for a handful of nuts instead of a handful of chips. Small changes can add up to big rewards.
It's about eating, moving, thinking.
Absolutely.
Yeah. Wow. This has been incredible and such a fascinating discussion. Thank you so much for all of the updates, Dr. Zelovitzky.
Thank you.
And for leading this new program here at Medcan. I know you're helping so many women, and it's amazing. So thank you.
Thank you, Marisa, for helping create this program that is helping so many women. I hope to help many, many more in the future. So please reach out to us if you think we can be of benefit to you. You don't have to suffer in silence.
And that's what we want. We want to help women. So thank you.
Absolutely.